You're good. Now? Okay, good morning. I'm Dottie Blakesley, Chair of the Family Support Planning Councils. The Family Support Planning Council was created by New Jersey law to give families a voice in the system that cares for people with disabilities. We work closely with state agencies and with families. The presentation that we see on the screen that Kyoko will be sharing in a minute gives more detail on the council's accomplishments and how to join your local council. All presentations and relevant information will be emailed to you after the session. Kyoko Koko, the council's coordinator, will have everyone muted except for the speaker. I'd suggest putting your Zoom on speakers mode so it's clear who's speaking. If you have questions, please put it in the chat. Kyoko and Carrie McGrath will monitor the chat and will manage the questions during the Q&A towards the end of the session. In a minute, I'll turn this over to Cathy Tamburello, Vice Chair of the Family Support Planning Councils, to introduce this session. She will be followed by Bev Roberts from the ARC of New Jersey to give an overview of Social Security and medical coverage. That's a very broad subject, and we've asked her to do it in 20 minutes, so good luck, Bev. Our speakers, Margaret Hefferle, Jen Boyle, Lisa Parles, Joanna Miller, will share their personal experience and what they've learned. This will be followed by Cathy Tamburello and Andie Iannuzzelli, who will talk about how to get the most out of each doctor's visit. Kyoko and Carrie will then start the Q&A. Now I'm turning this over to Cathy.
Good morning, everybody. I'm Cathy Tamburello, and today's topic, which is managing the medical care of your loved one with an intellectual and developmental disability, came from a discussion that a number of us had about how some of us have managed that very daunting task. It also came from a discussion that we had where we talked a little bit about some of us, what might we do if we could do it over? Could we do it better? Did we learn a lesson? So we want to share those kinds of insights today as part of this presentation. Very often, providers are not familiar with the unique needs of our loved ones. Many are uncomfortable with individuals who have trouble answering questions or may need physical assistance. This was outlined very clearly in a recent New York Times article that Dottie shared with us, where a focus group of doctors gave input on how they felt about having patients with developmental disabilities. The name of this article says it all. These doctors admit they don't want to see patients with disabilities. So we really feel that this is an important and timely topic, and we have amazing speakers today that will address these needs. In addition, insurance coverage, whether it's Medicaid, Medicare, or private insurance, presents additional layers of challenges. All of this, I can speak from personal experience, leaves families very, very frustrated. So today we'll talk about these challenges, lessons learned from our families, and we will answer some of your questions. With that, I will turn this over to our first speaker, Beverly Roberts. Bev is the Director of Mainstreaming Medical Care at the ARC of New Jersey. Bev?
Thank you so much. I'm now going to do is share my screen. Okay, hopefully everybody can see the screen. As Dottie said a couple of minutes ago, this is a daunting task for me to do everything that I talk about, usually with a full presentation for each topic, and blend it into one short presentation. So here we go. The first thing that I want to talk to you about is something called Medicaid unwinding. This is a term that many of you may never have heard about, but for anybody who has New Jersey Medicaid, this is a term you really should start to become familiar with. So the public health emergency, or PHE, started back in March of 2020 at the start of the COVID pandemic. While the PHE is in effect, no one should be losing their Medicaid. However, the PHE will end at some point, even though right now we don't know exactly when that's going to be. And the term Medicaid unwinding refers to what will happen when the public health emergency officially ends. At that point, New Jersey Medicaid will mail redetermination paperwork to everyone who has New Jersey Medicaid. I also want to emphasize that this does not apply to people with SSI and Medicaid, because their Medicaid is part of the SSI bundle that started when their SSI started. But for everyone else who has New Jersey Medicaid, this is something that's going to be important for you. So anyone who receives New Jersey Medicaid must respond promptly to Medicaid redetermination paperwork, and failure to respond can result in a Medicaid termination. When the PHE is scheduled to end, I will be announcing it to my listserv. Anybody who wants to sign up can go to my website, www.mainstreamingmedicalcare.org, and then scroll to the bottom, and there's a place to sign up for my listserv as well as other listservs that people at the ARC of New Jersey provide information on. So there are things you can do right now prior to the end of the public health emergency. For anyone who has a maximum of no more than $2,000 in resources, which is a lot of the folks that have New Jersey Medicaid have that maximum. And there's also a $2,000 maximum for people that have SSI and Medicaid. Do not exceed the maximum amount of resources that your son or daughter is permitted to have. That's something you can check on now and figure out what should be done with any amount of money in resources in the bank that's over that $2,000 level. The exception is if anybody has received a back payment from Social Security, you have 9 months to spend that down to the $2,000 level. You can consider an ABLE account if that's appropriate. You also want to be sure Medicaid has the current mailing address, because lots of people have moved since March of 2020. If Medicaid doesn't have the current address and then the PHE ends, and they send Medicaid redetermination paperwork to the old address, and then it gets returned because there's no more forwarding on that, then your son or daughter doesn't get the redetermination paperwork, and then they lose Medicaid just because they never got the redetermination paperwork that you're supposed to get. So what you would want to do, if there's any question about whether or not they have your current address, call 1-800-701-0710 and confirm that New Jersey Medicaid has the current address. And anyone who's notified by Social Security that their loved one's current SSI and Medicaid are going to end, don't delay in submitting necessary paperwork to New Jersey Medicaid. The current status of the PHE, it was recently renewed by the U.S. Department of Health and Human Services, which means all New Jersey Medicaid members will continue to remain enrolled at this point as they have since March of 2020. The current information is that the next possible date for the PHE to end would be April of 2023, and we are supposed to get at least 60 days of advance notice. Therefore, by middle February, we should know whether or not the PHE would be ending in April or be extended again. I know there are some people that the whole family may have New Jersey Family Care information. And so I'm not going to go through the details on this slide. I think you're all going to get copies of this. But if the family that has New Jersey Family Care, if as a family they exceed the income guidelines that they were eligible in March of 2020, but if they're not eligible now, then those families will end up losing their New Jersey Family Care Medicaid as a family when the PHE ends, and they then have to do a redetermination. They'll do the redetermination, but if their income is over the limit, then they will not be able to have NJ Family Care anymore. So it's really important also for families to know that their son or daughter with IDD can stay on the parent's health insurance after age 26. So as you probably know, up until 26, All young adults can stay on the parent's health insurance, but a young adult that doesn't have a disability, that coverage will stop on their 26th birthday. So for anyone that has a son or daughter with IDD and has private health insurance from an employer, before the 26th birthday, like 3 months before, the parent needs to go into HR, request a form from the employer. This is a special process for young adults with disabilities who are not capable of self-sustaining employment to allow them to stay on the parent's employer's health insurance for as long as the parent has that health insurance. This does not mean that the young adult cannot work. They absolutely can work. It's just that the income they have from employment is not going to allow them to be self-supporting. The form would be filled in by the parents and then taken to the doctor, and the doctor would certify that the person has a disability and they're not capable of self-sustaining employment. It's fine to have private health insurance and also have Medicaid. Medicaid is always the payer of last resort. And we have a fact sheet on private health insurance, which can be requested if anybody would like to see that. I'm going to talk real briefly about the difference between SSI and SSDI because families are often understandably confused about the different terminology. SSI is supplemental security income. The determination for this is based on your son or daughter having a severe disability and very limited income and resources, meaning below $2,000. SSDI is Social Security Disability Insurance, and it is based on Social Security's determination of a disability, but also on work credits. A Section 1634 DAC is a disabled adult child who is receiving SSDI from the parent's work record. So helpful suggestion for anybody who's in a position to be applying for SSI for their son or daughter. There are two attorneys, Tracy Kahn and Risa Rohrberger, who do a really helpful webinar entitled Potholes on the Road to Getting SSI. And they provide really helpful information for families to know when they are doing that SSI application. To see the slides and a recording of the webinar, it's available on my website, www.mainstreamingmedicalcare.org under the What's New heading. This, again, I'm not going to, I have no time to go through all the details on this chart, but this is a Medicaid eligibility chart that lists the name of all of the ABD, aged, blind, or disabled Medicaid categories in New Jersey. That's the stuff that's in green on the left side of the slide. On the right side of the slide in blue is NJ Family Care Medicaid expansion. So at your leisure, certainly you can take a look at this slide because you'll have a copy of it. It's also on my website, and don't hesitate to ask if you have any questions about it. ABLE accounts. So ABLE stands for Achieving a Better Life Experience. It was legislation that was passed at the federal level back in 2014. It says that people with disabilities can deposit up to $16,000 a year in an ABLE tax-exempt savings account. To be eligible, the person must be receiving SSI or SSDI with an age of onset of the disability before age 26, which of course is not a problem for any of our family members or loved ones who have to have a disability before age 22. You also could open an ABLE account for a spend down when applying for SSI. In addition, after SSDI starts, if there's difficulty spending the additional money, opening an ABLE account may be helpful. ABLE accounts will not affect continuing financial eligibility for Medicaid, SSI, and other public benefits. This is a link for anyone who wants to know about opening an ABLE account in New Jersey. You can also open an ABLE account in any other state, and a very good source for anybody who wants to know everything there is to know about ABLE accounts is the ABLE National Resource Center. Here's the link for their website. They have great information. They have webinars that are free, state-by-state comparisons, lots and lots of helpful information. I'm going to read to you the last bullet because this is also important for you to know. Upon the death of the beneficiary, the state in which he or she lived may file a claim for all or a portion of the funds in the ABLE account to recoup costs paid by the state while the beneficiary was receiving services through the state Medicaid program. So it's important to be aware of that. Okay, so a lot of our folks have SSI and Medicaid. And then there are questions, what happens to that when a parent starts to collect their Social Security retirement benefit, or when a parent becomes disabled or passes away? So previously, when a person with IDD had SSI, and then a parent either retired, became disabled, or passed away, the switch to SSDI and DAC status, DAC meaning disabled adult child status, was automatic. However, currently, parents are being told they need to do a new application to Social Security before DAC status takes place. I have heard some reports of denial for DAC status because Social Security said that they didn't have sufficient information to prove that the disability started before age 22. This is obviously very troubling because the person already has SSI. I don't really understand why this is happening, but it is happening. So it's important for families to be aware of this and what families can do when they are collecting all of their medical and IEP documents to submit for SSI. Save all of those documents to provide to Social Security again during a reapplication process later on. I'm now going to give you the actual Social Security definition of a Section 1634 DAC, which again stands for Disabled Adult Child. This is the Social Security definition. A person who was receiving supplemental security income or SSI benefits and Medicaid, and who meets the following: at least 18 years of age, having blindness or a disability which began before the age of 22, has been receiving SSI based on blindness or disability, and has lost SSI due to the receipt of Social Security benefits on a parent's record due to the retirement, death, or disability of a parent. And also the person can't have more than $2,000 in resources in that person's name, not including either a special needs trust or money in an ABLE account. This is a screenshot of the DAC flyer. We at the ARC had a lot of input into it, but it was done by, you can see the logo in the upper right-hand corner. It was done by the Department of Human Services. It's helpful information about DAC status. And in particular, on page 2, there's information that's very specific as to how to get Medicaid again after losing SSI benefits. So anyone who has SSI for their son or daughter knows that when you get SSI, you're not doing a Medicaid application. You've done an SSI application. When that's approved, Medicaid starts automatically. Therefore, when SSI is going to end due to retirement, death, or disability of a parent, and then the son or daughter is going to get money from the parent's work record, the SSI Medicaid package that started at the same time is going to end at the same time. And that necessitates submitting a Medicaid application to New Jersey Board of Social Services. And this part of the flyer describes exactly what that entails. And the DAC flyer is available on my website, and I can also send it to anybody who would like to see it, the actual DAC flyer. So again, when SSI Medicaid is going to end because of a parent's retirement or disability or passing away, you must apply for New Jersey Medicaid. And you'd want to use something called the RFI, Request for Information Medicaid application, not an ABD medication, not an ABD application. Now, these applications really are the same. The difference is the RFI, Request for Information Medicaid application, has the words Request for Information at the top of the first page. The advantage to doing that is that when that is submitted to the county Medicaid office, it basically tells them this person previously had SSI, was already approved as having a disability. And so they don't have to determine does the person have a disability for ABD Medicaid. It's basically just how much money do they have in their resources. It's supposed to streamline the process and save aggravation for the family. So again, in doing the application to New Jersey Medicaid, the RFI, the son or daughter with IDD cannot have more than $2,000 in resources, with a few exceptions. Funds in an ABLE account are fine. Up to $16,000 can be deposited per year. Funds in a special need trust are fine. If there's been a back payment from Social Security, you have 9 months to spend it down to the $2,000 level. So even though I've been talking about SSI Medicaid is going to end, we are still in this PHE, public health emergency, and therefore nobody should be losing Medicaid at this point for any reason. Nonetheless, if this status pertains to your family member, please don't delay in doing a Medicaid application through this RFI process. To say a couple of words about special needs trusts. If you're setting up a special needs trust, please be sure the attorney is very experienced with this type of trust for a Medicaid beneficiary. There are lots of nice attorneys out there. This is not the time to go to somebody's, your neighbor's cousin's friend who's a nice person and thinks how hard could it be. What you really want to do is be sure the attorney is very experienced with this specific type of special needs trust. If there's a special needs trust that's been funded, Medicaid is going to want to review the document. They'll scrutinize the document. If you have any expenditures that you're going to make from a special needs trust, save all receipts and follow all Medicaid regulations. This is something that I think a lot of families may not be aware of, so I've started to include it in every Medicaid presentation that I do. Whenever a person with IDD is employed, there is something to remember. It's called SGA, or Substantial Gainful Activity. This is a regulation from Social Security. To be eligible to receive SSDI benefits, a person must be unable to engage in what Social Security calls substantial gainful activity, or SGA. And a person who is earning more than a certain monthly amount is considered to be engaging in SGA, and therefore would be losing their SSDI income. The SGA maximum for 2022 is $1,350 a month gross income from employment. So families should be reporting income to Social Security Administration every month. It's important to know that just because you've reported the income, you can't assume that that means everything is fine. Like if you report it 1 month and the next month you don't hear anything from Social Security, don't then assume everything is fine, there's no problem. You want to know that your family member has monthly income below that SGA level if you want them to continue to receive SSDI. If an employee who receives SSDI exceeds that SGA threshold, expect to lose SSDI and receive a letter from Social Security requiring payback for an overpayment. I cannot overemphasize how important this is. I've been talking to families, not a lot, but some, who are getting letters now back from 2020, when their son or daughter exceeded SGA back then and Social Security stopping the SSDI and requiring an overpayment of thousands and thousands of dollars from over 2 years ago. What I've been talking about is specifically SSDI income. If somebody is receiving SSI income and their employment is over the SGA, then their SSI amount is going to be reduced. And there is lots of information on Social Security website about substantial gainful activity. So the issue of having both Medicare and Medicaid, which makes a person or puts a person into a category of being a dual eligible. SSDI can start on the employment record of the person with IDD themselves, in addition to starting on the work record of a parent who has collected either Social Security retirement or become disabled or has passed away. After having SSDI for 24 months, Medicare starts automatically. And parents are very often very surprised because everything they have to do is do an application for this, do an application for that, but not for Medicare. When a person has had SSDI for 24 months, then the Medicare will start automatically. And again, having Medicare and Medicaid, that person becomes a dual eligible. Medicare is always going to be the first payer, but if a person is also receiving private health insurance from a parent who is actively employed, then the private insurance is first payer, Medicare is second, Medicaid is last. If the parent receiving the private health insurance, however, is retired, then Medicare is primary, private health insurance secondary, Medicaid last. With regard to having Medicare, and again, I have to just go really quickly because I don't have time to launch into all of the details about Medicare. But one of the aspects of Medicare is something called Medicare Part B as in boy. For anyone that has Medicaid and has Medicare, then the New Jersey Medicaid pays the cost for Medicare Part B. A letter would probably come saying there's going to be a big monthly deduction, but New Jersey Medicaid is going to pick that up. Usually for the first couple of months, the Medicare Part B fee would be deducted from the Social Security benefit. Then the problem should be corrected automatically. We have 3 fact sheets on dual eligibles with IDD, which are listed here. They're available on my website. And I hope it stayed within the time frame. This is my name again, my email address, signing up for my listserv, www.mainstreammedicalcare.org. And the next person who's going to speak is Margaret Hefferle. She's up next.
Good morning. As Bev mentioned, my name is Margaret Hefferle. I am, sorry, I can't tell. Is my PowerPoint up? Oh, great. Okay. Anyway, I am a nurse with Special Child Health Services in Morris County. I am also a parent of a young man with autism, not so young, 33. And I'm also the chair of Council 1 for the Family Support Council. That council follows Morris, Sussex, and Warren counties. So Special Child Health Services is funded by the State Department of Health. And as I mentioned, we're county-based. So there is one in every county. And the people there who work there are nurses and social workers with pediatric experience. Many of the units are based at hospitals, but some are at the County Board of Health and some have other hosts. We follow children with special medical needs from 0 through their 21st year. And we're pretty well connected with a lot of the other departments under the Department of Family Health. Okay, next slide. So there are many ways that children are referred to us. It could be from the newborn nursery, where they do a lot of screening for children for a number of special medical needs. through the neonatal intensive care, and like I said, through all the testing. So someone comes to us with a diagnosis. Might be something really simple. By the time I call them up, it may be resolved. Sometimes more diagnoses after we talk to the families are established so that we can kind of help the families direct some of their care. Also from SSI applications for children, there is a family cost share, but when someone applies for SSI for a child with special medical needs, we get notified as well because that child has been, if they get SSI, declared disabled. We also get catastrophic applications through the New Jersey Catastrophic Illness in Children Relief Fund. And we can also get referrals from doctors, from parents themselves. All they really need to do is call their county-based unit and ask for a case manager. Next slide. Well, you know what, I just want to, sorry, can I refer back? Just wanted to talk about, I will talk more about the newborn screening, but there is a birth defects registry in here in the state of New Jersey. It's still up on the website. We like to call it the special needs registry. We used to be housed, special child health services case managers used to be housed with the early intervention unit in pretty much every county. That has changed. So now we're a little bit more separate. Some are still housed together. It was a really nice handoff. In 2009, they developed an autism registry. I have to say, as a parent of a child with autism, not a lot of people knew about autism back in the day. He was born in 1989, but they know about it now. And I have to say it's changed the way we work because I believe our caseloads are about 75% autism because we do follow kids through their 21st year. So we can help with a lot of things down that way. And then, you know, certainly other special medical needs. Okay. So as I mentioned, there's a lot of screening. They can screen for 60 disorders through a blood test. They do screening in utero. They do for cardiac effects. There's a huge program for early detection of hearing loss, referrals for genetic screenings. And genetics, I mean, used to be we didn't have a lot of kids that went to a geneticist. Now they almost all do. And sometimes that identifies some of the syndromes that are not as common as they used to be. So I had mentioned the birth defects registry. So we can go to the next slide. And, you know, those testings are all determined by law. So even the autism registry back in the day, you used to be able to do it anonymously. And a lot of families like to do that. But then what they didn't get was a call from their case management unit to help them. And so I do have families that have more than one child. And they say, boy, I wish I had this when my older child was diagnosed. And I said, well, yeah, could have, you know, but unfortunately. And so all that testing, it's done because it's really important to intervene early. We could just move on to the next slide. So I mentioned the birth defects registry. There are over 300 diagnoses that are registrable, and the registration is done by the diagnostician, the hospital, or the primary care provider. And most of the time it's used for statistical purposes. I remember back in the day with autism, they were looking for clusters. But, you know, probably the most important thing is that it gets a call from a case manager. There's also a cancer registry. So we can move on to the next slide. So as I mentioned, a registration is completed by the state. They fill out all the information. It gets down to the county level. Actually, the State Department of Health sends people a letter saying that a registration has been done and that they should be hearing from a case manager. And then about 2 weeks later, we get the information and we call the family. I usually refer to that because families don't always remember getting the letter, and then they feel like it's a little big brother. How do you know? You know, because sometimes these are like little heart defects or, you know, number of diagnoses. I mean, there's so many. But, you know, we just say, hey, you know, we're asked to reach out to you to, you know, offer any help or resources. And it's important, you know, to connect those families to care. So the next slide, please. So our focus is that every family has a primary care provider, referrals to any medical specialist that they may be, that they have a medical home. I remember attending a conference in the year 2000 that said medical home by 2010. And that was the idea that pediatrician's office would be your medical home. They would be the one that oversees care and, you know, helps kind of keep track of all the specialists. So what are we, 2022? You know, it's probably not being done as it was designed. So we make sure families have insurance in place, referrals for needs. We develop individual service plans, and we help families advocate through various agencies. You know, if they need to be referred to early intervention, if they need to be referred to the child study team. We keep updated lists. I just got a recommendation from a family the other day of specialists that are welcoming to families. I have to say, I do see with a lot of my families that sometimes doctors aren't welcoming to those 18 and above. We don't see it so much with younger kids, or at least that's not what I hear. Next slide. Oh, okay. So, you know, like I said, we can refer to local doctors. One thing that's probably important is to, is that if your special child health services unit is based in a hospital, they usually know all the pediatric staff. I know a lot of people ask me for adult doctors, and I say, I don't really know them, but I know all the specialists well. We can refer you to specialty clinics. Some clinics for certain diagnoses are a team approach. So they call it a clinic, but it's really a team of doctors in all the areas that your diagnosis might be involved in. And sometimes those are out of state, but then it's important to have a local doctor so that you can do the blood work before, you can do the MRIs or things like that, and in case an emergency arises. We also refer to early intervention. A lot of kids come to us before the age of 3. And so if it's appropriate, if they need therapies, we refer them to early intervention. Sorry, I guess we're a slide too far. And we also refer to the school district child study team. We're pretty good with the IEP process. And then we refer them to agencies like Perform Care and, you know, down the road, DDD. So right here. So ideally, your primary provider is your medical home. I think it's important, even though you have a pediatrician down the road, that's really nice that you have someone that's affiliated with a medical center or a children's hospital, perhaps even better. They tend to personally know all the specialists that they're involved with. They communicate them all the time. They will have their own set of medical records. I don't know, a number of years ago, every doctor I had a different login, and I could never remember the passwords, but typically, at least with Atlantic Health, it's called My Chart, and everything is in there. You can call and you know, ask for something, and that conversation is recorded. You can email. So it's a little bit better with the communication. I know at my hospital is Goree Children's Hospital. They have grand rounds twice a week. So they're usually up on care. So a number of recommendations. Try to request a care manager at your insurance company. They're going to be somebody who knows doctors that are in network and help you keep costs down. And it's a name and a face that you know and you can call rather than cold calling. They may not be local to you, but they may have a lot of information. As I mentioned, sorry, next slide. You know, there are specialty clinics that have that team approach, and you know, I have families that go once a year, but then they get their care otherwise. One thing I have to say, New Jersey partially funds child evaluation centers for individuals with developmental disabilities. Sometimes it's called the Child Development Center. Right now, they are completely booked. And I think Bev mentioned you need documentation before the age of 22 that you have a developmental disability. And sometimes find as kids get older, you might need you know, some input from them, and you need that paperwork all in transition when you're applying for DDD or SSI and things like that. And once you're out it's really hard to get back in, especially if your kid is nearing adulthood. And then, you know, just some other, sorry, next slide. So paperwork. As I said, ideally, your pediatrician is your medical home. It's you. At the end of the day, it's you. I actually have a paper that's been sent out about the shared care plan. It's a document that you can fill out, keep track of, chronological history, because chances are you're not going to remember it. Take notes at the visit so that you can put it in your care plan. A list of specialists, when you're sitting there in the office and you have to fill out that paperwork yet again, it's insurance companies and things like that. At the end of the day, take this 27-page care plan, make it your own. You know your child's best. And it's easy to share that information when you have that with you. And now I'm going to introduce Jen Boyle.
Good morning, everyone. I'm going to adjust this. Can everybody hear me okay? Wonderful. I'm Jennifer Boyle. I'm going to be talking about managing medical care for an individual with complex needs, and especially offering a family perspective on this topic. And I'd like to start just by asking people in the room if you have a family member who has complex medical needs. If you could raise your hands. It's very common. And so some of the things I'm going to mention will be familiar to you for sure. I wanted just to start by my next slide, just to give you a picture of my family. This is the five of us, because we have a dog. Now we have 2 dogs, but our family consists of my husband, Neil, myself, my son, Sean, who is in the picture in the wheelchair. He's 19 years old now. And my son, Sam, who is 16 years old. And then we have our dogs. We live in North Caldwell, New Jersey. We love to hike. As a matter of fact, the rest of my family is hiking right now, and I'm going to be joining them later. We love to go to new places. We love to have family adventures. We love to sing. So we really enjoy ourselves and enjoy all the things that New Jersey has to offer. I'm going to go to the next slide. I'd like to share a bit about my son, Sean. Sean was born in 2003, and I might say I think he was the most beautiful baby I have ever seen. Pink, kicking, gorgeous. Maybe I'm a little biased, I don't know, but he was born at full term, 7 pounds, 11 ounces. He had 8 and 9 APGAR scores, and we were delighted. But pretty soon after he was born, we had some significant concerns that became obvious. Sean was not able to take a bottle. He did not have a gag reflex. So some of the most fundamental reflexes and abilities that babies should have, he did not have. And so we realized very quickly that something big had occurred. We did not know what. And so things unfolded. So Sean was diagnosed with profound spastic quadriplegic cerebral palsy as an infant. And he also developed epilepsy that was very hard to control. He had his first seizure when he was 14 months old, and I will never forget it as long as I live. I don't know how many of you have experienced seizures in your family, but they're traumatic, aren't they? You never get used to them. And he actually was later diagnosed with a developmental delay and an intellectual disability. And I should mention here that in addition to these concerns and diagnoses, that Sean is a joyful person. He can see perfectly, he can hear, he has learned how to read, he can do math, he enjoys being in nature. So he's so much more than just these diagnoses, even though these diagnoses are significant and really impact our family life. We began doing therapy, medical visits, and consultations right away, because I can tell you this, looking back, I can describe all of these things, but at the time I had zero clue about what was going on. I just knew something was wrong. And I did not know where to start with getting my feet under me again to be his mom. So that's where we started. And I'll go on to my next slide. There were a lot of challenges in managing Sean's medical care. The first thing was, oh, I'm so sorry. Here, I'm going to get close. Is that better? Okay, I never want to be too loud, but I want to be sure you can hear me. So first of all, we needed to see some specialists right away. We needed to see a neurologist. We needed to see a developmental pediatrician. I learned all of this. And then I couldn't get in to see anybody for quite a while in some cases. And I was surprised by this, especially those initial appointments. Remember that when you were trying to get those first appointments, it takes a long time. There were very few available in-network therapists. Sean needed PT, OT, speech, and I called around and I couldn't find people that were on our insurance, covered by our insurance, to see him. Insurance companies were not especially cooperative. I'm going to say they were uncooperative in trying to help me. They would answer my questions, but I did not feel that they were doing their part to help me manage the care of my son. And the fourth issue, the fourth big challenge, is that for Sean, he had complex, interconnected medical issues. And sometimes this would result in conflicting direction from physicians, where I was getting information that did not match up and I did not know what to do. And although we are all supposed to have a medical home, that fell to me, to figure out, like, what do I do here? Also, sometimes treating one of Sean's medical issues would worsen another one. And then I didn't know what to do either. What's the most important factor? What's the most important thing to address? The last issue, and this is still an issue for us now, my son has private duty nursing. He qualifies for private duty nursing. Nurses are very, very hard to find. And so these are some of the challenges that I was facing. I'll just give one example of the interconnected medical issues. So when Sean was small, he had a lot of difficulty taking a bottle. And even at the beginning of his life, we weren't sure if he was going to be able to feed by mouth. He might need a peg tube. And so we got a meeting, but it was hard for him. And so he wasn't gaining weight. So I went to the pediatrician. They bumped up his calories. They said, we should try to give him a more calorie dense food so he can get more nutrition. So we bumped him up to a different formula, and then his reflux got worse. And because those formulas are harder to digest. And so then he was throwing up, and then my initial effort to help him made things worse. So then we tried some other things. We tried bumping up some of the sugar and fat once he was able to eat in his diet, still trying to keep him eating enough. And unfortunately, the sugar in the foods I was feeding him worsened his seizures. And we were not able to control his seizures adequately. And then he was in the hospital from seizures, and then losing more weight, losing strength. And so I could see that the things I was doing and the things that the doctors were advising for us were well-intentioned, but they were making more problems in addition to solving problems. So does that sound familiar to anyone, like trying to manage all of this? This is really hard for a parent. And so that's just one example. And I'd like to share some helpful practices, if I might. That's my next slide. Some of these are very simple, but these things really help me personally. That's why I wanted to share them. First of all, I would recommend, wherever you can, being what I call a politely persistent squeaky wheel. I have been squeaking now for the last 19 years, whenever I can. A small thing, when I could not get Sean in to see a specialist, I called regularly to check for cancellations. And this is so simple. I was always pleasant. I asked, like, how are you doing? Did anybody cancel? And you know what? Sometimes you hit the jackpot and somebody did cancel, and there you are on the phone, a nice parent, and they just give you that appointment. Sometimes they even remember to call you back. So this is really important. This got us in to see specialists who could help us faster. So I would always recommend that. The second thing is, this is really important, and you probably have experienced this yourself, denials from insurance for things that seem completely obvious that your son or daughter needs. Do not take that no as the last word. It's not the last word. It's just, honestly, what it means is not now or not yet, not yet. Appeal denials until they are overturned. Don't stop. There are many levels of appeal, and now there's external appeals available. Many things for my son were approved on external appeal. I'll give one example. Sean has very limited motor skills. He was sleeping in a platform bed, and he was falling out of bed. We put bean bags all around his bed, pillows, and I couldn't sleep at night because I was listening for him to be moving in his bed. So finally, we applied for a sleep safe bed, and he did not qualify for one because he was not bed bound and he was not an eloper. And I found this to be ridiculous, you know, but here's what I did. I went into his room during the night. Over the period of a week, I took pictures of him right on the edge of the bed. Before I got him back in the bed, I apologized to him, but I took a picture of him on the beanbag on the floor. And then I sent the appeal with those pictures. And you know what? We got our bed because it was ridiculous that he would not qualify for this. Be creative with these appeals. Put a picture in the appeals. It really helps because a human being is looking at that paper. Who is going to tell my son who is laying on the floor on a beanbag chair that he does not need a bed that will keep him on his mattress? So that's important. The other thing is, with physicians, do what you can to help them see your son or daughter as a competent, whole person. Some very simple things. My son uses a communication device because he's not able to speak. We have programmed into his device for him to be able to introduce himself, or if he doesn't feel like it, to say hi. I ask the doctors to ask him questions. If they don't ask him questions, I ask him the questions, and then he answers himself in the way that he can do it. Last slide. Time flies when you're up here talking, I can tell you that. Make the most of your physician and therapy visits. Have a goal for each visit. Because there are complicated needs, talk to the doctor about what your goal is. My goal is to help my son gain weight without worsening his reflux, is a great goal, for example. When you're seeing a new physician, bring a written history with pictures and also the things that your son or daughter enjoys, right? So that they can see them as a whole person. Last but not least, two things here: network and connect with other parents. Parents know what to do because they've done it already. Network with other people. If you don't have a parent group, start a parent group. You will benefit from it so much. Last but not least, bolster your optimism, energy, and creativity by taking care of yourself. Do not forget yourself. Remember yourself. And with that, I will say thank you for your time. And also, I will turn it over to Lisa Parles. Thank you.
Good morning. Thank you, Jen. I think Kyoko is going to bring my slides up. So while she's doing that, let me just take a minute to introduce myself and to talk a little bit about my son, Andrew. So I'm the mother of a 32-year-old man who is nonverbal, has severe autism, complex medical needs, and challenging behaviors. I'm also the partner of Parles, which is a New Jersey law firm that represents individuals with disabilities and their families. I'm the board president of Circle Haven, which is a not-for-profit that's developing a campus-based farm community in South Jersey, and the founding board member of the National Council for Severe Autism, which is a really wonderful resource, a national advocacy organization that not only does advocacy work at the national and state level, but also is a really good resource tool. Obviously, our presentations are very compact today. It'll be brief. And you see my slides, if you just got the handouts, they're very long. Let me explain what I did there is that I'm just gonna have a few slides for what I'm talking about this morning, but I did include the slides from 2 presentations that we're commonly asked to do. The first is the one you see, the key questions when selecting and creating a program for individuals with IDD and challenging behaviors. That actually in your handout starts on page 6, so you can look through that at your leisure. And the second one, which starts at page 14, that's covering innovative residential models, really answering the question about what is permitted now to use your HCBS funds, what are states allowing, what are the feds allowing. And I think both those areas are really important when you're addressing an individual with challenging behaviors. You have to look at the weeds of the program they're in, or even if you're doing self-directed, the program you're running, in terms of what are we doing when we look on a daily basis with respect to how the programs run, what kind of data systems we're using, what kind of communication systems we're using. And then also to look more at, the 60,000 feet view where, well, what about the model itself? And that's the second part, because I really do believe that the campus model has a lot of advantage to it for individuals with this kind of profile. Next slide, please. So I just mentioned these are some advocacy organizations that have lots of information about the weeds, program descriptions, and also advocacy work for just models themselves. And next slide again. I don't probably need to tell anybody this, what research is showing in terms of what the challenges are and how families are feeling and the kind of fears that they have, and how hard it is sometimes to put these type of systems in place. I just want to say that obviously understand and recognize that. I did also make the point just a moment ago about sometimes the freestanding group home models are not the best way to address it. Next slide. Okay, so these are really the key points I'm going to make for you today, but let me just take a few minutes to talk about my son, Andrew. Prior to his 19th birthday, Andrew, while he was nonverbal and cognitively impaired and really needed to be taught everything in very small increments and systematically, he's really classically autistic, he had no behaviors. His behaviors didn't start until his 19th birthday, which is not uncommon. A large percentage of individuals will, in the late teenage years to the early 20s, be the time when their behaviors either begin or intensify. His behaviors surrounded food. So he lost his appetite. He began to have behaviors even when he just saw food. Sometimes it would then affect not only not wanting to eat, but not sleeping. I think in the worst of it, the longest he ever went without eating was 5 days. We were always just on the brink of just thinking about hospitalization. And sometimes he didn't sleep for up to 3 nights at a time. Again, unfortunately, not uncommon, but the challenges of trying to get a handle on that are just a long, long journey. His included 3 surgeries for detached retinas, traumatic cataracts, and probably most importantly, getting the migraine and vertigo diagnoses, because I think that really helped us address his, not solve it, not eliminate it, but certainly reduce it and understand it better when we got those diagnoses. But it was a very, very long time to do it and a web of specialists. The second piece, though, was also that we really had to work on developing a very specific database program that was going to track and, more importantly, analyze his behaviors when we attempted to address them. So let me just turn to probably the 4 most important points. Some speakers have already talked about this, and you're going to hear further about ruling out medical causes, which should always be your starting place. So in my practice, I've seen examples of people that behaviors, again, seem to come out of nowhere, but we then discovered that the person needed dental work, had an abscess tooth, or a broken finger, or declining vision, or reflux. I mean, there's so many things, and particularly when you have individuals with no language or limited language or the inability to communicate, it is a very difficult path. But if you can rule out some of them and then address them, then it can go a very long way. The second piece is about tracking behaviors with sufficient data and details. Now, lots of programs will say, oh, yes, we're a behavior-based program or a behavior analytic program. This is the materials in the second half that I gave to you. There's some real specific questions I think that you have to ask and look at when you're looking at a program or when you're running your own program to try to put in place, is that there is detailed data. So when they're just taking time-based data and then can tell you X percentage of the day this happens, it's not going to be nearly as effective as the specific data, like something like ABC data, that they're looking at every incident, looking at the antecedent, the behavior, the consequence, when it happened, who was with them. And there are fortunately now a growing list of technology that can assist with this, a number of programs like Rethink Autism or Catalyst, that not only it makes it easier to track, but can do some of the analysis for you. So you could pull up and say, gee, let's see, does this happen at a certain time of day or during a certain activity? And it can do the work for you. But if not, you know what, sometimes paper and pencil works just fine as long as you get some help setting it up. But that's really important, because if you take data and it's just being recorded somewhere, but no one is analyzing it and then changing the plan as a result of the analysis, it's not only not helpful or effective, I think it's actually even counterproductive, because it creates this, almost this untrue vision that there's really a data system and some analytics going on. Another important part is effective communication systems, and that has to include staff, families, and clinicians, and not separately. Everyone's going to be involved in that triangle. I mentioned that I'm working with a project called Circle Haven. We're running a pilot home now, and we have a grant we're working on with Rowan University. And we're really testing a lot of those systems that are looking at some simple things that almost all programs are going to have, shift to shift, but also systems using things like Google Chat. So when you have something important to communicate, like for instance, a med change, or maybe a change in the behavior plan, that, when this happens, we're not going to address it, we're going to ignore it, that everybody knows, and there's a way for people to actually read and acknowledge, and you can check that the information's gotten to everyone. So that's really critical too. The next one, which seems probably like a real simple thing, and I've actually seen it in a couple other programs that I've seen in other states, is the value of having prompts and checklists for staff themselves. So for example, having assigned that each person has a particular, not only role, but job, and is responsible for it, of things that we do as parents and don't even think about it, but could have a big impact. Like, for instance, right now we have, for one of our positions, they have to check the weather before they put Andrew to bed, because with the changing seasons, one night you need heat, one night you need air conditioning. If someone doesn't check that and set it accordingly, you could wake up in the middle of the night with a behavior, and it just turns out that he's really cold or really hot. Having something like someone that has to check each shift that they've cleaned his sunglasses, those type of things that he's not going to know or be capable of asking for himself. What I mean in terms of prompts too, so in addition to checklists, prompts can even be a prompt within the environment, like a picture prompt. So maybe someone will say he really does expect to get his hair brushed after he first gets dressed. Let's have the hairbrush right there, where in his bedroom, near his dresser, we put a picture of the hairbrush right on the dresser. So it would help staff. There's a lot of information to share, and no matter how many clinicians or professionals you have on your team, no matter how much detail you think that you can provide with writing it down, it's almost impossible to create a document that shows all of that. We try, because it is important to have protocols, but I think you have to do those type of things that could help. But the most important is probably the fifth point I wanted to make, which is that when you have training, I know that we have a lot of things available for DSPs, a lot of materials, a lot of resources, but when you're training on an individual, you really have to have a shadowing component. There's nothing more valuable than having a knowledgeable, seasoned staff showing a new staff, this is how we do it. We put the shirt on first so he's not cold. Those type of things don't get into documents, and they can make a really big difference. Oh no, don't give them any of the red gummy bears, those type of things that parents will just instinctively do, but not necessarily think to tell. And my last point I wanted to say is that we use in the onboarding process a parent intro video. So do a 30-minute video where the parents get to talk, and every time someone new comes in, they watch it, telling the person's history, talking about some tips like that. Oh, he loves videos, but you're going to have to rewind them for him, or even telling some positive stories. So they see the person as a whole person, and they also can think of the person as being able to enjoy things and do things. And lastly, I think it also helpful for parents to talk a little bit about how difficult the decision to put your loved one's care in someone else's hands, whether that is if they are placed or even in your home when you hand them off. It is the most difficult thing for parents to do. We always feel that, if only there were more of us to do it, the way we're doing it. And not that we can't do it. We can do it all the time by ourselves. We often need help and support and other ideas to do it. But I think talking to people about what an important role they feel and how difficult it can be with parents it's really important. I've had so many staff members tell me that, they've never really thought about it from that perspective. And I think it really helped all of our relationships. So I think I went about a minute over. I'm going to say thank you for your time. And obviously there's lots of information in the handout. I hope it's helpful. And I would like to just turn it over to our next speaker, Joanna Miller.
Okay, thank you. Good morning, everyone. It's great to be here. I'm just going to share my screen, make sure everyone can see that. Happy to be with you. I am Joanna Miller. I'm the Executive Director for the Department for Persons with Disabilities, which is a part of Catholic Charities in the Diocese of Paterson. I've been with the organization for 25 years now. I've been in the field for nearly 30, and I am grateful to be here, grateful for the invitation from Dottie Blakesley. She and I have been working together on many parent-provider relations work groups, so happy to share some information with all of you relative to that. Down here. Okay, so I was asked to just talk a little bit about providing a roadmap to care when you are working with a provider organization. So obviously the first and most important thing that has been stated by everyone so far is providers need to know all that is needed to provide the best care for your loved one. For us, that starts well before admission and continues throughout care for the individual that we are supporting. I encourage all of you to be as thorough and accurate about your loved one's support needs to set everyone up for success. The more that we know about your loved one, the better that we can support his or her needs to be successful and to achieve all that is needed in quality care for your individual. It's a team effort, as has been stated. The family, guardian, if that happens to be someone else, provider leadership, staff who know the individual best, the clinical team, the medical professionals, support coordinators for us are also included at the adult level as well. Ensuring all of the needs of your individual are clearly spelled out in the person-centered planning tool and then in the ISP. Provide other summaries to inform care. I love the idea of the video intros. I think that that's something as a staff member and someone who needs to know your individual best, that would be a wonderful tool for all of the staff that work with the individual have. I highly encourage that. I know Jen also talked a lot about the documentation, as did Lisa, around data and analytics and all of that. And that is very, very important to ensure we all know the best approaches. Meet with the provider often and those who do provide care. Review and revise the support needs. As you already know, meeting annually is often not enough. So we encourage you to do that often. Provide that detailed information about those specific preferences, the likes like the red gummy bear and not the yellow gummy bear. Especially what does not work. That is very, very important. And sometimes those details are missed. Communication is key. When things are going well, obviously to keep that going. And when things are not going well, make sure that you know the communication protocols within each provider organization. This is something that we've been working very, very hard at the state level with DDD about and with all of the families to make sure that that is clear. And if you are working with a new organization, make sure that you speak to them and that that is provided to you in writing, what their communication protocols are within the organization, and then through DDD and the provider management unit and beyond. Partnering in medical care. We'll talk a little bit about that just through the process and medical appointments and how we navigate it at my organization, DPD, as well as other provider organizations that I'm familiar with. Training staff on how to conduct medical appointments. That is very, very important for us as the ones who are typically charged with that responsibility. If you or the family is not there or is informing the process, but may not be present at the visit. So that shadowing component that Lisa spoke about is a big part of what we do, modeling those interactions, focused on the individual, ensuring that the medical professionals are interacting with that individual, as Jen Boyle had said earlier, is very, very important. So we take that to be one of the primary responsibilities as someone is accompanying an individual to a medical appointment. Provide us always with the list of providers. That seems like a simple thing, but not only the preferred ones, but non-preferred ones. Individuals that you may have worked with in the past that you wouldn't want your loved one supported by. That's really important for us to know. Scheduling appointments, who manages this? So in our world, it is really important for us to be involved in that process so that we can provide transportation, provide staffing support, ensure appropriate follow-up in that process. So it is a team effort. That's something that we usually take the lead on, but certainly willing to partner with families as needed to make that work. So just be clear with the provider organization about how you see that manifesting over time. Participation in appointments with families and provider staff. Again, it's that team effort that we all need to work together to manage that and decide who is the point person on communication and sharing of that information after appointments as well. That goes with providing and ensuring good communication and documentation of those appointments. Of course, from a provider's perspective, we need to make sure that we have the proper follow-up and care and that that's communicated to everyone that is working with that individual, supporting him or her. And then, of course, from a licensing perspective and other auditing entities that come in, that is something that they look at the provider level. Have we done everything that is required to follow up for an individual's care? And are we seeing that through and documenting all of those particular interventions that are indicated for that individual? So that is really, really important for us. And then lastly, just a note about turning care over later in life. We all know that time does happen and there may come a point where you may need to turn care over to a provider agency or to someone else in your family. It may not just be with a provider, but just plan for that. Communicate your wishes in writing. That is something that is very, very important. And that goes to all aspects of that, whether it be, end of life planning, who the individual might be best cared for by, and please designate alternates in decision-making, who will be responsible for speaking in your absence. Obviously, I'm sure you've talked about advanced directives and all of those types of things for end-of-life decisions, but just making sure that that is part of the process as you work with a provider organization so that all are clear in that. We are here to be part of that partnership. And, I'm just grateful to be here. Thank you for the opportunity. And now I'm going to turn it over to Cathy Tamburello and Dr. Andie.
Thank you so much. Can you hear me? Okay, good. So I'm going to talk a little bit about the visit, the all-important doctor visit. And I'm also going to talk a little bit about organizing it so when I'm not there and I'm no longer in charge of my son, that my daughter can take over. And I'm going to then throw it over to Dr. Andie, who is going to talk a little bit about the Risen Center, which I would love for them to develop that model all over the state, and how we can also be supportive to the providers to make sure we get the most out of our visits. So I am the mom of Michael Tamburello, who is 37 years old. He has Charge syndrome, which is a very rare syndrome. I find when I go to doctors, they look at me blankly. They don't know what it is. So I'm always ready with my Charge syndrome fact sheet so that everybody understands all the ramifications of Charge syndrome. I find that I talked about in the beginning about how some of our initial conversation on this day today came from, what have I learned? What would I do over? What I would do over is do a much better job of organizing all of the things that have happened medically over his life. As Jen said, when Michael was born, it was very complicated. Nobody knew what Charge syndrome was. He was born with completely obstructed nasal passages. So you can just imagine what happens when you put a bottle in his mouth. There's no air flowing. So it took a lot to get through all of that, and it was very overwhelming. I can tell you the history, but I can't tell you the dates and the exact times because I didn't keep a log at that point. Now, with electronic records that you get with doctor's offices, it's a little easier to download what happened and where the appointments were, but it really is important to keep that history because that history will come back over and over again. It certainly has in Michael's case. The other reason why I find that history is so important is Michael's sister is a 32-year-old mom of 3 and an OT, and someday will be the person responsible for dealing with all of Michael's needs, which again are pretty darn complex. So now what we have done is I have the binder system in my house. I have binders for Michael's everything, Michael's documents, Michael's medical, Michael's Medicaid, all of that. So I really look at, you can go to the first slide, Kyoko. Thank you. I keep a binder of all the basics, and everyone's talked about that already, but it has all of his documents. I have sleeves with all of the cards. I have all of the medications. His medication list, Michael lives in a group home. His medication list is 7 pages. So of course they include things like sunscreen on that, but there's a lot. His appointment log, the treatments and strategies he has. Michael has severe osteoporosis, so I need to know the dates of the Prolia shots. When was the last reclass infusion? And now I'm starting to organize the patient portals because this is, I think, fairly new. All of a sudden, a lot of these doctors are part of big corporations, and there's these patient portals. Unfortunately for us, Michael's care is not all in one system, so there's multiple portals. And so now I have to remember the passwords and the where that information is located. But I also am setting it up so that Jenna, my daughter, has access to it as well. And all of these lists, the ones that I generate, the doctor's list, the medication list, all of that is now in a shared Google Drive. So Jenna can access that at any time. If I get hit by a bus tomorrow, which we hope will not happen, she has everything at her fingertips and can just take over. So I find that to be, really important. You can go to the next, oops, do we have the slides, Kyoko? Oh, you did it virtually, okay. So as I said, the next slide is just an example of the Charge syndrome fact sheet. But, it's really funny that this came up today. I've spent my whole week on Michael's medical issues. And I too agree. It's important for people. Michael is not verbal, so he cannot express himself and explain what the problem is. So we have a current problem going on. Michael's falling a lot, and he's very banged up, and that's a problem. So I spoke to his primary, and I love what Margaret said, the idea of a medical home. I am lucky enough, and I encourage all of you to find a primary who gets you and your loved one. I really feel our primary, his name is Dr. Romeo Caballas. He's in Branchburg. If you're in that area, use him. He is our medical home. So I needed somebody to evaluate Michael's spine. He has severe kyphosis. And I started calling one orthopedic group that we had used. Oh, they said, he has a syndrome. We don't do that. But you should really call this place. So I made the next phone call. You really need to go to a big center that specializes in people like your son. And I said, there is no such place. It was 7 phone calls. and I had nothing. So I called Dr. Caballes. He made a phone call to a wonderful doctor that we saw yesterday, and it was very productive. But the point of this is, as much as it is important for the doctor to see your whole person and to understand the individual, it's also important sometimes to help them separate. Yes, he has developmental disabilities. Yes, he has intellectual disabilities. Yes, he's nonverbal, but you know spines. Can you look at his spine and tell me how bad that curve is, if there's something we need to do, or where else I need to go? So I think that becomes, I know for me, has been a big challenge. Doctors tend to see him. They're very intimidated. Can we get a blood pressure? Can we do this? Can we? Yes, you can do all of that. And I just really need you to give me an answer about the problem, which again, as everyone has said, to go in clearly. Yesterday, when I did go to this doctor, I had, this is what I want out of this, on a paper that was handed to him with all the medications and the Charge syndrome fact sheet. And it was a very, very productive visit. So I think it's, really important to do all of that. I am Michael's quarterback for his medical care. Michael does live in a group home, but I do manage all his doctor's appointments in collaboration with the group home manager, and I take him to all his doctor's appointments. I just find, for me, I have the whole story. I can give the story and I can keep everything together. And as Jen so well said, what one doctor wants to do can very well affect another system or another piece of Michael. But I also rely on my primary, and when Michael had pediatric care, it was great because, pediatric care is very caring and, he's a cute little guy, but it becomes harder to find that primary that really will help you coordinate and help you get to the answers that you need. And I did rely very much on Dr. Caballes, and he was incredibly helpful. In the end, I involved my daughter in all of these decisions. She's a working mom, and she lives in Massachusetts, so she obviously cannot be present for all of the medical appointments. We phone her in as much as possible. And if not, it's a conversation that we have on a regular basis so that she knows what the issues are. And if she had to step in, she can do that. Succession planning, as we all get a little older, becomes a big issue, and we want that continuity. What Michael ideally needs in a perfect world is he needs that team. He really needs everything in one location where the doctors look at him as a whole and bring their specialties together and come up with a coordinated plan of care. And for us, that's been an incredibly difficult thing. Michael also has a lot of he has two endocrinologists, one for hormones and one for bone density. And we had a great endocrinologist here in New Jersey who just finally said, he's beyond me, I can't treat him. And said, you need to go to a center. And that's so hard because if you have to go to a big center, like you just call the National Institute of Health and say, hi, I have Michael, this is what I need. It's a very difficult thing to manage. So ideally in a perfect world, and that's why the Risen Center, I think, has so much to offer, but they're so far away from us. That idea of coordinated care. So I'll turn it over to Dr. Andie to talk a little bit about the Risen Center and how we can best partner with the providers and give the information and do the things that we need so that so we get the best care for our loved one.
Thanks, Cathy. So as Cathy mentioned, I'm Andie Iannuzzelli. I'm a physician at Risen Center, and Risen stands for Rowan Integrated Special Needs Center. So we are part of Rowan University's medical school, the School of Osteopathic Medicine. And Risen Center opened in 2019, so we're a relatively new practice. We are a primary care practice that focuses on special needs adults. So we care for individuals who are 18 and older, And our team consists of myself and another couple of medical physicians, Dr. Jennifer LeCompte and Dr. Jeffrey Zlotnick. We also have a couple of behavioral health providers, Wendy Ada, who is a psychologist, a PhD, who is the co-director of our organization, as well as Dr. Fola Ajayi. She's a psychiatric nurse practitioner. We've got a couple of social workers on staff, Jen Airy and Man Yip, who are LCSWs, who help us with gaining resources for our patients as well as counseling our patients. And then we've also got an amazing staff of support people. And we're located down in Sewell, New Jersey, and many of you from North Jersey may be saying, where the heck is that? And it's in Gloucester County. And so as Cathy referred to, we're kind of far away from a lot of you. We service primarily the lower 7 counties. So essentially from Burlington County south. We do make some exceptions if people are like at the southern tip of Mercer County or, Ocean County, and they're not too far from us. We do make exceptions, and we'll accept patients from other counties as well. But what we pride ourselves on is being multidisciplinary. And we not only care for the patients, but we also coordinate care for the patients. And this is a challenge that I've heard the previous speakers talking about, like coordinating the care for their kids is really difficult especially for their adult children. Seems like when they're pediatric age, we've got these amazing places. I've got a son, Nicholas, who's 24 years old. He's special needs, and he has been the motivating influence for my joining Risen Center. I was a kidney specialist up until now. Nick has multiple neurologic issues. He was a typical little guy until he got to kindergarten. And then he started having seizures and then was diagnosed with something called Lennox-Gastaut syndrome. And from there, the downward spiral began. He ended up a few years ago having a brain tumor, developing neuropathy. So he's complex. What I learned is that we were so blessed to have Children's Hospital Philadelphia right across the bridge, and they kind of took care of everything until they didn't. Because he's 24, and at some point you've got to age out of a pediatric center, and it was kind of like, well, he's fallen off this cliff. So that's what Risen Center's there. We're there to catch people when they're falling, so that we can help get you referrals to specialists. Because once you age out of the pediatric system, it doesn't mean that you don't need a neurologist anymore or a gastroenterologist. You just need one who specializes in adults. And fortunately, we've developed a really nice relationship with Children's Hospital Philadelphia. They recognize that we have a valuable service to perform. So they'll give us a phone call, they'll email us, hey, we've got a patient that we're working on transition planning. We're sending them your way, and they keep us in the loop. DuPont from Delaware also does the same thing. If I had my way, there'd be a Risen Center in every county, or at least every region of New Jersey. And that's something that I think, we can shoot for in the future. But for now, we're in the lower 7 counties. But what I think is really important, and some of the speakers have already alluded to some of the things I'm going to mention, is when you're meeting a new provider for the first time. We've got our new patient packet, which is pretty thorough, but it doesn't tell the whole story. So what's wonderful is if you bring some old records with you. So we have maybe the last note from each of the specialists that your loved one sees. So we can scan that into the record. Not all EMR systems communicate with each other. And so even though, your records may be in EMR systems, doesn't mean that they'll communicate with the one that all the other providers have, unless you're at a self-contained center. An accurate medication list. We'll have parents that come and they'll bring the medication list, and we'll review it, and they'll say, well, yeah, they're supposed to be on that twice a day, but I'm only really giving it once a day because the stool softener caused diarrhea. So it's really important to have an accurate medication list. And, because our kids are so complex, oftentimes it's easy to come in with this whole, we have patients who come in and they're like, oh gosh, Yeah. So they're having diarrhea, but also we need to address something on their foot. And also, you know, I think they have sleep apnea. And so it ends up becoming like this flight of ideas, which I get because my son has really complex medical issues as well. But if you can write down your concerns so that there's some focus and organized fashion to the visit. And then really what I like to do is ask our clients, our patients, as well as their caregivers, okay, we've got a lot to tackle. If I could help you with one thing today, what is that one most important thing? And what also might need to happen is if there are a lot of really important things that need to be tackled, you know what? Maybe we do a visit every 2 weeks until we have everything at a steady state. And not every visit needs to be in person. Ideally, the first visit should absolutely be in person. Thereafter, you know, like I had a patient that I met this past Thursday, really complex. And I told her caregiver, we're going to meet every 2 weeks until I feel satisfied that we're in a good place. So we're alternating in-person visits with telehealth visits. And fortunately, with the advent, that's one of the silver linings of COVID is that we do have more access to telehealth, whereas we didn't used to in the past. So I'm hoping that's one of the benefits that will persist after the public health emergency has passed. Another point I'd like to make is before you leave the office, make sure that you've got a follow-up visit. What has happened is, you know, we'll send the patient home from our office. They'll stop at the front desk to, you know, get their information packet or any referrals that we've got. And they'll say, well, I'm not going to make an appointment now. I don't have my calendar. I'll call you later. Well, maybe we want to see them back in a month. And they call back in 3 weeks. Say, okay, I'm ready to make my follow-up appointment now. Well, guess what? Now we're booked up. And so now we can't see you for maybe another month or even 2 months. So it's really important to make that follow-up visit before you leave the office so there is continuity of care. At Risen Center, because we're interdisciplinary, we have an interdisciplinary meeting every 2 weeks where the social workers, the behavioral health people, and the medical team will all meet and discuss particularly challenging cases. So that's one of the benefits of being at a center where there is an interdisciplinary team. You're not always going to have that. And it doesn't mean that the primary care practice isn't absolutely wonderful. As Cathy's expressed, she's had an amazing experience with her team. It's also important to have a team that will just pick up the phone, that isn't afraid to pick up the phone. For example, when those insurance denials come through, you know, I pride myself on my track record. I'm 0 for I don't know how many when it comes to persistent denials. So if I feel that a patient really needs something and the insurance company is denying it, I pick up the phone and I get on the phone with the medical director and I explain to them, you know, think about it. If this were your kid and this is what you're going through. And I put it in words like that. And I've not ever had a medical director that I've talked to that has not reversed the denial. So it's important to have a team that's really going to advocate for your child. You know, at Risen Center, one of the things that makes us different is not only this interdisciplinary team, but we also have a desensitization program that Dr. Ada, our psychologist, does. So we desensitize patients for sexual health exams. It's really scary, even if you're neurotypical, to have your first pap and pelvic exam. And just because you have special needs doesn't mean you don't need sexual health to be addressed. So sometimes it takes us a year or even longer before we're able to do a pelvic exam on someone. But Dr. Ada has a desensitization program that she works on for sexual health exams. She works on desensitization for needles. So for vaccinations and lab draws, we have a de-escalation room. So one of our exam rooms actually has beanbag chairs. It has really low level lighting, no fluorescent lights. It's kind of a soothing, we've got a lava lamp there. We have pet animals that breathe and they purr like cats, stuffed animals that purr, and our patients can pet them and be soothed by them. So we have that for our patients who really are ramped up and anxious or very nervous. And sometimes the med students and residents who train with us just like to go hang out there for their lunch hour because it's so relaxing.
Andie,
yeah.
Dottie, I'm really sorry about this because you're sharing some really, really important information, but we have a Q&A session and I don't want
Sure. Yep. So So in closing, thanks, Dottie, and I apologize for taking longer than I should. So in closing, you know, Jen Boyle, Lisa Parles, Cathy already reflected a lot of what I said, but you know, make sure that you come armed to advocate in a nice fashion, as Jen, I think, emphasized, in a nice fashion, and make sure that you express to the physician and the team that you want to be part of the team. You don't just want to be a parent, but you want to be part of the team so that there's shared decision-making. That's hugely important as well. So sorry for taking too long, and I appreciate everyone's attendance.
Okay, so it's time for the Q&A. And Kyoko, you're going to read the questions out?
Sure. Okay. So the first question is from Cathy, and I think it's for Bev. How soon before retirement do you need to contact Social Security before a parent retires?
So if you're talking about contacting Social Security, it's usually part of when the parent is going to be announcing or picking a date for their own retirement and whatever they need to set up for their retirement. That's when there would be a discussion, which should be in the records of Social Security anyway, but it's, you know, that you have a son or daughter who's receiving SSI and need to start the process to establish that that person is going to get SSDI on the parent's work record. And so that then would start, in all likelihood, the application that you have to fill out, the whole new application. But even before you're actually officially doing that, you can be in the process of gathering, if you had kept information from when you applied for SSI so many years ago, if you have it or can find it, that would be great. If not, you could also try to start to reach out to the providers that you had contacted way back then to see if they still have the records, if they can provide the records for you. If you don't do that, Social Security will contact the providers that you indicate on the application form that they should contact. But it might work out better if the parent is the one reaching out to try to get those records, because Social Security sends a letter, and if it's ignored, oh, well, it's ignored. And then they just say, oh, well, we never heard back from so-and-so. And then they can deny the application based on not having heard from those providers whose names you had given them.
Thank you, Bev. And I think it's a related question. The other question is, who do you ask for the RFI, request for information Medicaid application, prior to retirement? Okay,
so you're not going to do the RFI yet. That's so in terms of like a timeline, the parent is going to be, you know, processing for their own retirement. Then now, because Social Security has decided that you also have to do this brand new application, so there's going to be time that's going to elapse while that's all being worked on. And so then at some point, and I don't know how many months later, but at some point after all of that, then hopefully the SSDI, the transition to SSDI will be approved. So then comes a letter saying that, you know, very specific from Social Security that SSI and Medicaid are going to stop, that SSDI is going to start on a certain date and how much money it's going to be. That's the point. When that letter comes, that's the point when you would want to get the RFI. If somebody already has DDD services, and I believe Cathy's son does, then it should be coming from DDD. At the point where this is all happening with the transition over, that's when you should get the RFI. Hopefully the support coordinator would send it. If not, let me know. I think most support coordinators should be aware of this, but there are always new people that may not know as much. But it would come from DDD, the RFI. If the person does not yet have DDD services, meaning maybe they've applied, but they're not actually enrolled in either supports or the CCP within DDD. If that's the case for somebody, then they would have to get the RFI from the County Board of Social Services.
Thank you, Bev. Another person asked about dual eligibility, but I think you touched that in the presentation. Someone is moving from New York to New Jersey, and her question was, how does she able to find a doctor who takes Medicaid? I think the question is like before she moved into New Jersey.
So I'm not sure if that question is coming to me or to somebody else.
Or maybe.
But I would like to just suggest, and anyone else can certainly answer, in terms of what needs to happen to get New Jersey Medicaid, because we do hear from people from other states. It's not, if you have it in another state, that's fine, but that doesn't mean the day you come into New Jersey that you have New Jersey Medicaid. So I'd like to suggest that that mom send an email to me at broberts@arcnj.org, and then we can go through like exactly what's going to happen in order for her family member to be able to get New Jersey Medicaid.
Thank you, Bev. And Bev's email address is included in her presentation slides, and everyone will get presentation slides copy and also link to the recorded session. Okay, so let me move on to the next question. But before we move on, like anyone who wants to share your tips from the meeting room? Okay, so hold on. Go ahead, Eileen.
Okay. Oh, good morning, Bev. I wasn't prepared to share tips, but I did have a question just for the whole process of switching and reapplying when your loved one already has been on SSI for many years is kind of a little overwhelming. Just wondering if there is a way to view that RFI application before we have to go through it, kind of a thing. Is it published anywhere? Just to see how long it is and what we're looking at really.
Okay, so what it really is the ABD Medicaid application, which is available online. If anybody wants to email me, I can send it.
Okay.
So it's it's just the ABD application, but the difference is because it's called Request for Information. I don't know why they picked that title for it, but that's what's being used. So I had actually talked to a mom not long ago who thought, well, what's the difference? Because there is so much similarity between an ABD application and a request for information application. And so in the changeover from SSI to SSDI, she submitted the ABD application. And who knows, maybe it was just whoever reviewed it at the county. This is one case, so I can't generalize to everybody. But she had a ton of aggravation. They were assuming that this person didn't have a disability, even though he did have SSI, switch over. It was just all sorts of trouble for mom. Whereas I haven't heard about that when a person is in this changeover and uses the request for information application. Hopefully the Medicaid staff understand what that means, right? You don't have to establish the person has a disability. Request for information indicates yes, they did have SSI before. So you don't have to go through hoops to say the person has a disability, but they are going to scrutinize the resources. So that's what they would be really, putting their attention on to make sure that it's under the $2,000, as I had mentioned.
Right. Okay. The other question, I mean, maybe a silly question, you probably already covered it, Bev, but so when we're applying for Social Security, so there's a flag, I guess, that goes up if you have a child with a disability, or is the parent supposed to let the representative from Social Security know this information when they are applying?
Yeah, it's always good to let them know. I mean, I hear different things. Yes, it should be available in the system, but you just never know who you're going to talk to. There are new staff. There's been changeover of staff over the past few years, both in Social Security and in Medicaid. So just to be sure, I think it's a good idea for the parent who's filing for their own retirement to be very clear that they have a son or daughter who is currently getting SSI and, is going to need to switch over to SSDI. Okay. And then one more thing, because I tend to hear about problems and I don't have data on the number of people who have aggravation with this, but there are times, and I think it could be that they didn't provide information on the disability before the age of 22, or they had the doctors or IEPs information was given and then Social Security supposedly sent out for that information, didn't get it back, maybe didn't read it. It's so hard to know, but there are occasionally people who are turned down. Again, I only hear about problems. So maybe I'm hearing about a teeny tiny number of people who get turned down, and then they have to go through an appeal and hire an attorney. So I don't want to frighten people to think they're going to have to do that. But because there's a lot of incompetence there at this point, I am seeing people who have been turned down who absolutely should not have been turned down.
Well, we definitely want to avoid that at all cost. One thing, and Kyoko had mentioned tips, and just piggybacking on Andie's presentation, I think that it's important to show an ISP of your individual. If you're going to a new center and you want them to get to know your child, that's very comprehensive. It lists behaviors, it lists, medications, it lists level of cognition, it lists everything. And so I think that that's a good resource. That's what I do. That would be a tip that I would say. Just if you're seeking new medical attention from, especially from a group like the Risen Center, I think that would be valuable information that they would have.
Absolutely. Thanks for bringing that up. Yeah.
Thank you. And since Andie, you're unmute yourself, next question is probably for you and also anyone who live in the northern region. So the question is, I live in northern New Jersey. Will Risen Center see clients from my area? If not, what do you suggest?
That's a great question, unfortunately. So it depends on how far north you live. But typically, as a rule, we do not see clients from North Jersey because we're a primary care practice, and you really ideally should be relatively close to your primary care physician. So we do have exceptions. For example, if someone's going to be coming into a group home down in South Jersey, or someone's going to be moving down here for some reason, and you're trying to, preemptively get your adult child involved with our practice, then we will make an exception. And as far as specific physicians or groups that we refer to in North Jersey, we don't have a referral service for primary care practices in North Jersey. Unfortunately, I think that would need to be word of mouth, and maybe people here have a suggestion of who they use that they're happy with. Cathy Tamburello certainly does.
So I just wanted to say that DDD funds 2 developmental disabilities clinics that do primary care. One, and I actually just looked on the website. They're through Atlantic Health. One is in Union, New Jersey, and one is used to be in Morristown on the campus, but now it's in Cedar Knolls. And the address isn't updated, but you have to be 21 and you have to have Medicaid.
Thank you. And am I looking around in the meeting room? Does anyone have a question? Okay.
So Bev, excuse me, Bev, I was given 2 questions to ask. And the first one was, if my child has insurance through my insurance post age 26, and I change my job, is my new insurance company required to provide insurance for that individual, my child?
No, they are not required. And it's very unfortunate because so many times parents who perhaps might want to get a different position feel that if continuing private insurance is extremely important, that they stay in that job because of that. Now, they certainly, if they're being considered for another position after age 26, the parent could ask, would it be possible for their son or daughter to still have the private health insurance in moving to a new position with a new company? It's not a requirement. And so as far as I know, it doesn't usually happen, but I suppose if the new company really, really wanted to bring that other person on, that perhaps it could be something that could be negotiated. I don't think there's anything that would prevent the company from doing it. I just know that very often companies just don't want to. They don't have to, and they don't want to usually.
Okay, thank you. And then, hold on, there's one. The last question that I was given was if I die, is my insurance company still required to insure my child? That for Bev.
So I think it really depends upon the way the HR, structures the benefit. I mean, in a lot of cases, when a parent retires, the private health insurance ends with the parent's retirement. In some situations, the private health insurance continues while the parent is alive and in retirement. I actually don't know of any situations where the private insurance continues after the parent has passed away. I don't know if anybody else knows anything about that, but I haven't heard that it would continue.
Bev, I've seen it in self-insured plans where the company just, as a courtesy continues the rest of the family for a period of time where the employee passed away.
But is it for what kind of period of time? Is it more like a COBRA continuation?
It's sort of, again, depending on what they want to do for the family. It's totally voluntary, but I've seen the company do that.
But probably not long term, right?
Right, exactly.
If they are continuing it, it would be for a specified period of time.
Correct.
Yeah, I think those are for very specific circumstances. We have one more question, and then I'm going to wrap this up.
Thank you, Daddy. Hi, Beth. My question is, if you have a child with young adult with complex medical and mental health conditions, and they get the support in a different state. Like my son is part of CHOP, and now he transitioned to UPenn Medical Center. He has number of specialists there. How can we use his Medicaid to cover those services?
So do you have private health insurance also?
We do, but right now private insurance is covered. But after a few years, we are wondering how is that going to solve for us, because he has about 6-7 specialists at UPenn.
So I don't have an easy answer. My answer would probably be risen because my hope would be, since you're South Jersey, presumably, yeah, that maybe that would be something that would work for you. But could also separately, because I know we're short of time, could you send me an email? Because I would also like to maybe talk to you a little bit more. Sure. So if you could do that, it's broberts@arcnj.org.
Sure, I'll do that. Thank you.
Okay,
okay,
I want to thank all of our speakers. I mean, clearly you guys have a wealth of expertise and experience that you very generously shared with us. And I thank you. I did want to just sort of wrap this up. This is clearly not easy for any of us. If we know that a large part of the medical profession does have a bias against people with disabilities, just to find the right person is not easy. And then we have to start thinking about strategies to work under things like keeping good records, keeping a clear line of communication, and coordinated care. One of the things that I am a big proponent of is electronic health records. It's a great format for health professionals to check in with each other. It's a great format for families to use so that they can coordinate with their health professionals. If your person is living in residential and not in the family home, the agency would be able to participate in that record so everyone has a clear view of what's happening with your person. The thing that is really troubling for me is if your person lives in residential, there is no requirement for an electronic health record. The only requirement is that there is a medical record, but that record can be kept in the group home. No one else has to see it. So what does this mean? If you live in North Jersey and the group home is in South Jersey, in order for you to see that medical record, you've got to go an hour and a half to 2 hours to find it. That doesn't allow us to really be a full partner in the care of our people. the thing I'm supposed to be doing is implications for advocacy in this last bit. I think this is a clearly defined thing that we should be advocating for. So my request is that you talk to your support coordinator, your agency. If you get an opportunity to talk to anybody from the state agencies, DDD would be a great person to talk to. Let them know that we can do better. In this day and age, we should have a requirement for electronic health records. That's all I've got. Cathy, do you want to wrap this up, or that's about it? Okay, good. Thank you very much for participating. One of the other things that I think is really great is if you connect with your families. I know when Maddie moved into a group home, I depended on the regional family support people, council, my friends on a statewide level, my local region, very heavily. So, you know, I think it's a great group because there are regular meetings, there are quarterly meetings, there's an ongoing conversation with the state. You know, please consider joining us. Thank you.